there are patients that have chronic respiratory conditions like chronic obstructive pulmonary disease, right? People who are suffering, they can't take deep breaths. They have a lot of attacks,
Third
exacerbations.
leading cause of mortality in the United States.
Correct. These patients can have pain. Have you ever seen any COPD patients in clinic?
So not as much as you think.
Yeah.
I think data shows that COPD patients, 50% of them at least, have chronic pain.
Yeah.
But typically they're so focused on just breathing that the pain is like, I'll take it. Just get me at the next step so I can walk to the living room. And when we look at pain in COPD, it's in multiple areas. There can be inflammation in the lung itself, the lining of the lung, the pleura. There can be inflammation in their pleurisy. That's certainly one area. What's more common is the ribs, the intercostal muscles, the accessory muscles in their neck and their shoulders to help them breathe, to get those deep breaths. You often see them leaning forward to get this position where they can expand their lungs the most, and that causes chronic back pain. So when we look at this and we try to evaluate what's going on, you have to be delicate. You want to avoid opioids as much as you can because they're respiratory compromised.
Yeah.
You don't want them nodding out at night,
Not breathing, not taking big breaths.
they're not waking up.
Right.
Another part of COPD are headaches, typically either from low oxygen or too much CO2 when they're sleeping.
Right.
So these physiologic changes are best approached whatever we can do, whether it's CPAP, whether it's supplemental oxygen, those forth. We avoid injections into the ribs, into the intercostal, because if we get a pneumothorax where the needle goes too far and the difference between the nerve in your ribs and the location of the lung is about a quarter to a half an inch.
Yeah.
One slip mistake, the lung can collapse, and then you've got a heap of problems.
Right.
So the interventional things into the thorax, into the cage itself, are minimized unless it's something specific, significant, or whatever, broken ribs, say. And a lot of these people, because they're on steroids, they often will get osteopenia, thin bones. They'll cough and cough, they'll break a rib. And in those cases, injecting under fluoroscopic guidance into the fracture can be beneficial.
So do you inject into the fracture, or do you inject, and this is honest.
Yeah.
Or do you inject, like, I know when we're doing procedures, when I'm sticking a needle in somebody's back, I want to go over the rib because the vein and artery and nerve run right under it.
So we want to go below the rib because we want the nerve.
You want the nerve.
We want the nerve. So we'll go proximal, closer to the spine, from the fracture to anesthetize the intercostal nerve,
Yeah.
as well as put some anti-inflammatory medication in there to decrease the swelling.